So just give me a minute. Yeah, so I'll be taking a brief part on the operability or resectability of pancreatic neoplasms. And first of all, coming to the problem statement, pancreatic ductal adenocarcinomas, I think as already have been mentioned, is the second most common gastrointestinal malignancy after colorectal cancers. And the importance of having an adequate imaging or a report is to prevent an R2 resection in which there is a residual macroscopic disease. And in these patients with macroscopic residual disease, the survival is similar to that of a non-operated patient with a similar stage and performance status. The idea is to get an R0 resection and to assess whether an R0 resection is feasible in a particular patient or not. So the basic platform on which we evaluate pancreatic adenocarcinomas as with any other malignancies is the latest AJCC 8th edition guidelines, according to which the tumor staging or T staging is based on the greatest axial diameter of the lesion. The arterial involvement of the celiac, superior mesenteric and common hepatic arteries, if they're involved, are classified as T4. However, no further mention is dealt with in the AJCC classification, and for evaluation of the vascular anatomy related to the pancreatic malignancies, we would like to fall back on the NCCN guidelines. And the venous involvement as such is not at all taken up according to the AJCC guidelines. And one point I would like to mention, pancreatic ductal adenocarcinomas usually do not have calcification except in the cases of a prior pancreatitis in which the calcification has been engulfed by the present ensuing mass. However, if that is not the case, a neuroendocrine tumor would be a more probable differential and will have to stage the malignancy according to the neuroendocrine tumor guidelines for AJCC, not by the exocrine pancreas guidelines. Coming to the very basic diagram, I think sir has already demonstrated this in his talk. The medial border of the superior mesenteric vein or the extrahepatic portal vein forms a marker of which differentiates between the head and uncinate process of the pancreas from the body and tail of pancreas. So anything onto the right side of this green line needs a Whipple's, and onto the left side of this line it needs a distal pancreatectomy. And coming to the much debated topic of resectability, unresectability, and borderline resectability, the basis of a resectable tumor is that it does not have any relation to the major vessels that supply the liver or the bowel, such as the celiac artery, the hepatic arteries, and the superior mesenteric arteries. And also, the superior mesenteric vein and the portal vein are not distorted or involved by the lesion, and there is adequate amount of intervening fat plane so that there is a scope of adequate resection margin along these vessels. However, in case a gastroduodenal artery is encased by a tumor with rest of the other mentioned arteries not in close proximity with the tumor, the lesion is still resectable. I'll come to a first case, and there is a focal hypoenhancing area in the uncinate process of the pancreas, which is around less than 2 centimeter in maximum diameter. There is some amount of perilesional fat stranding anterior to the lesion, which does not extend up to the superior mesenteric vein. As such, there is a well-maintained fat plane between the lesion and the perilesional fat stranding from the superior mesenteric vein, as well as that from the gastroduodenal artery. So this is a bland resectable tumor, and being on the right-hand side of the medial margin of the superior mesenteric vein. So Whipple's would be the call of the day. And there are a few regional lymph nodes. These are along the common hepatic artery or the level 8 lymph nodes. This is an ancillary image showing the classic double duct sign. We have a dilated common bile duct and a dilated main pancreatic duct. Here the pancreatic parenchyma is thinned out, and with respect to the amount of dilatation there is of the pancreatic duct, there is far more amount of loss of pancreatic parenchyma, which we define as asymmetric pancreatic parenchymal atrophy, which is a secondary marker of pancreatic underlying pancreatic malignancy. However, if this amount of dilatation of pancreatic duct is there with maintained pancreatic parenchyma, it is usually seen with chronic pancreatitis, and the pancreatic parenchymal atrophy in that case is termed as symmetric pancreatic parenchymal atrophy. So we'll take on a few definitions before we go to the unresectable and borderline resectable tumors. The first one of them is an abutment of a vessel. If there is a less than 180-degree contact with the vessel, it is called abutment. And if it is more than 180-degree vessel contact, it is encasement. We can either go into the plane in which the vessel is seen in cross section and manually measure the angle to define whether it abuts or encases, or we can take an easier route in which if we don't see the vessel in actual cross section, we look for tumor tissue on either side of the vessel. If it is only on one side of the vessel, it is an abutment of the vessel. And if it is on either side of the vessels, then it is usually an encasement of the vessels. As such, the we'll have to confirm it on two planes in which the vessel is not seen in cross section to confirm whether we are categorically saying abutment or encasement. The vascular evaluation includes two particular things. First is the focal narrowing of the vessel lumen, whether it's an arterial narrowing or a venous narrowing. The venous narrowing being a more commoner feature than an arterial one, and irregularity of the vessel. This too is more common in venous involvements. As such, the vessel wall may be partially indented by the tumor tissue. In cases of post-chemoradiation or post-pancreatitis patients, there is good amount of peripancreatic fat stranding extending up to the vessels, the celiac, SMA, and the portal and the SMV. And in such cases, on CT, we cannot categorically mention whether there is any vascular involvement or not. However, we will have to take note of the amount of fat stranding, and it is always advised to check whether the fat stranding crosses more than 180 degree of the circumference of the lesion or of the vessel or not. In such cases, operability might be an issue. This is a schematic borrowed from one of the articles in Radiographics, and this shows the first row shows the arterial involvement by the tumor. The second one is the venous. In the first two images in each set, there is no deformity of the contour or the lumen of the vessel. However, there is less than or more than 180-degree contact. The first images being the abutment category and the second images being the encasement category. And then comes the luminal distortion, both in arterial and venous anatomical zones. Coming to the reasonably easier topic, the unresectable disease. Any distant metastasis and lymph nodes beyond the field of resection are unresectable. And when we need to evaluate unresectability as a part of vascular evaluation, we have to divide it whether the tumor is in the head and uncinate or in the body and tail of pancreas. If it is in the body and tail of pancreas and there is an encasement of the celiac artery with no involvement with involvement of the gastroduodenal artery, so much so that the celiac artery is not resectable, as the hepatic arterial supply cannot be supplanted from the superior mesenteric via the gastroduodenal artery. Then it is an unresectable tumor of the body and tail. I'll go through it again. A body and tail pancreatic ductal adenocarcinoma with involvement, that is encasement of the celiac artery, so much so that we cannot resect the artery, and as the gastroduodenal artery is also involved and there is no flow into the hepatic system from the superior mesenteric via the peripancreatic vascular arcade, then we cannot take out the celiac artery, and this becomes an unresectable category. Coming to the lesions in the head and uncinate process, any encasement of the superior mesenteric artery or abutment of its first jejunal branch is unresectable, and any head or uncinate mass, if it is in contact with the celiac artery, may not be causing an 180-degree or more encasement of the artery, is unresectable according to the NCCN guidelines. We will discuss about this again in the borderline resectable category. However, if there is a gastroduodenal artery involvement that extends up to the common hepatic artery and further extends into the right and left hepatic branches, so that after the bifurcation of the hepatic artery, the vessels are also involved by the tumor, this again becomes an unresectable. For venous evaluation, any tumor involvement of the superior mesenteric or the portal veins which is unreconstructable, as such, the length of contact being more than 3 centimeter is an unreconstructable disease, venous anatomy, and as such the tumor is unresectable in that case. And tumor involvement of the most proximal draining vein of the superior mesenteric vein is also considered a marker for unresectability. Apart from this, any invasion or encasement of the aorta and abutment of the IVC by a pancreatic head mass is a unresectable disease. We'll go to a few cases first. And this is the first case of unresectable disease that we'll be taking up at present. This is a celiac artery with the left gastric branch coming off, and immediately caudal to this level, there is a soft tissue. I need a pointer, I believe. There is a soft tissue structure just abutting the anterior margin of the celiac artery. So there is encasement of the common hepatic and the splenic by the soft tissue mass. And when we further go caudal, we can see there is tumor tissue on either side of the common hepatic artery. We will zoom this up for better clarification. This is the common hepatic artery, and there is hypoenhancing soft tissue on either side of this. Further down, when we go to the bifurcation level of the common hepatic artery, the right hepatic artery branches off and it is completely encased by the mass. The gastroduodenal artery is also encased by the mass, and we cannot take off the celiac artery because there in this anatomy we'll have to remove the gastroduodenal artery as well, along with the tumor, and the hepatic arterial supply might be at fault. Coming to the venous evaluation, this is a sagittal image showing an anterior-inferior indentation of the extrahepatic portal vein, and there's a reverse teardrop appearance of the portal vein by the lesion in the head of pancreas anterior to it. This is another axial image of the same patient showing long segment contact of the lesion with the extrahepatic portal vein. And pardon me. Okay. And coming to the next case, this is a body and tail mass encasing the common hepatic artery, branch point of the common hepatic artery, the splenic artery, which has a narrowed caliber and irregular proximal part of the I am extremely sorry. The mass encases the celiac artery and the proximal common hepatic artery. The proximal common hepatic artery lumen is irregular. We can see a amount of bumpy soft tissue which causes irregularity of the enhancing lumen of the proximal common hepatic artery. And the mass further extends anteriorly or ventrally to involve the posterior wall of the stomach, and there is an ulcerated infiltration of the posterior wall of the stomach along the lesser curvature. So, as of this point of time, the gastroduodenal artery, the rest of the common hepatic artery is seen separately, and the gastroduodenal artery is seen separately. So this is still a borderline resectable disease. However, when we go for the venous evaluation, the extrahepatic portal vein is completely encased and compressed by the mass. This is definitely involved, and this is not a salvageable disease. These are sagittal reconstructed images of the extrahepatic portal vein, which shows tumor on either side of the portal vein with a thinned out extrahepatic portal vein. This is another case in which we see a hypoenhancing mass involving the head and uncinate process encasing the right hepatic artery. A coronal image shows the tumor is on either side of the superior mesenteric artery. And this is a multiplanar reformatted image showing a common origin of the celiac and the superior mesenteric artery, except for the fact that there is a separate origin of the left gastric artery. This is a Michel 9 type of hepatic arterial anatomy, and on the sagittal image also we can see that the tumor is on the anterior and the posterior aspect of the superior mesenteric arterial trunk. So coming to the debated borderline resectable category, we will again go to the body and tail lesions because that's an easier topic. We'll finish it first. Any abutment of the celiac artery, that is less than 90 degree, less than 180 degree involvement of the celiac artery by the body and tail mass, is borderline resectable. However, encasement or completely encircling mass along the celiac artery is also resectable if at all there is no aortic involvement and there is an intact gastroduodenal artery, so that the hepatic arterial supply can be routed through the gastroduodenal artery from the peripancreatic arcade supplied by the superior mesenteric artery. And for the head and uncinate process tumors, any abutment of the superior mesenteric artery with less than 180 degree contact is an borderline resectable. And if there is an encasement of the gastroduodenal artery or the common hepatic artery, or a contact with the celiac artery, with no contact with the celiac artery or the hepatic bifurcation, and there is a possibility of safe and complete arterial resection and reconstruction, it is a borderline resectable category. However, according to MD Anderson and Alliance guidelines, they consider abutment of the celiac artery by a head and uncinate processed mass to be a borderline resectable category, as opposed to the NCCN guidelines, which consider them as strictly non-resectable category. For venous evaluation, any reconstructible venous involvement of the superior mesenteric or the portal veins or an occlusion of the same is a borderline resectable category. And again, the length of contact that can be reconstructed is usually less than 3 centimeter. So I have taken this case just for demonstration purpose. First disclaimer is there is a hepatic metastasis, which makes this lesion as an unresectable tumor. And then we will omit this finding and discuss about the borderline resectable categorization of this. The body and tail lesion abuts the celiac artery and the proximal hepatic artery. On a coronal image, it appears so much so that there is a possible more than 180-degree encasement of the celiac artery. However, a 3D multiplanar reformatted image shows that the body and tail mass abuts the celiac artery with less than 180-degree involvement. So again, this comes to the categorization of borderline resectable on the basis of arterial involvement. Coming to the venous evaluation, this is again a 3D multiplanar reformatted image, so that the image is a bit skewed. I have taken this up for a axial section of the extrahepatic portal vein. The contact with the extrahepatic portal vein is of less than 90 degrees, and there is indentation of the left lateral margin of the portal vein with a teardrop deformity. We can see that there are 2 horns on either side of the portal vein which are opacified, and there is an indentation at the center. This is a teardrop deformity of the portal vein that suggests involvement of the venous wall. And on the coronal sections, we see there is a small segment of contact with the extrahepatic portal vein. This probably can be easily resected and reconstructed. Coming to the CT-based classification system, I will jump to the grade 3. Any vessel that is encased on 2 sides or has contour deformity usually has infiltration of the perivascular neural bundles, and there is a high chance of positive resection margins if we just scrape out the tumor. In these cases, we need to have a resection of that part of the vessel if possible. And in cases of occluded vessels, the classic dictum is not to attempt a surgery. And few additional features we might look out for in the preoperative imaging is venous thrombosis, and if there is a thrombus, whether the thrombus is a bland or a tumor thrombus. Often it is difficult to differentiate. Tumor thrombus have enhancement similar to that of the parent tumor, but occasionally due to artifacts which are very common on CT, the differentiation becomes difficult. And if it is a clincher for deciding the course of treatment, then an MRI may be obtained in which a diffusion restriction within the thrombus will suggest it to be a tumor thrombus, and no restriction on diffusion weighted images will be a bland thrombus. When there is a thrombosed segment, we always look out for predominant collaterals to the portal vein and whether there are any gastric or esophageal varices. A few additional things that we need to look out for are the peritumoral fat stranding, whether they extend up to the vessel or not. This causes a surgical maneuver difficult because of the extensive amount of fibrosis in the perivascular region. and arterial variants, the most common of which is a replaced, most important for this topic of discussion is the replaced right hepatic artery. I think sir has already impressed upon the necessity to identify a replaced right hepatic artery. And I'll just go to a few images. The common hepatic artery goes in front of the portal vein and divides into the right and the left hepatic artery. That is the conventional anatomy. Whenever you see an arterial branch posterior to the portal vein, always try to trace it. This is another multiplanar reformatted image. The arterial branch goes up to the level of the superior mesenteric artery, and this is a replaced right hepatic artery. It is pertinent to identify the replaced right hepatic artery to reduce unintended surgical blood loss. There are a few more points. If time permits, I will go through them. These are the nodal staging. I think this has been discussed extensively, and I'll just browse through this. The peripancreatic lymph nodes are the pancreaticoduodenal, the anterior pancreaticoduodenal being along the gastroduodenal artery, and the posterior pancreaticoduodenal are the nodes that are between the uncinate process of the pancreas and the IVC. The superior and the inferior pyloric lymph nodes and the lymph nodes along the hepatic pedicle, that is along the portal vein and the common bile duct. Then are the regional lymph nodes. These are the perivascular lymph nodes along the celiac artery and the common hepatic artery, the superior mesenteric artery, and the middle colic artery. The arteries on the right and anterior aspect of the superior mesenteric artery are regional for a pancreatic head mass. However, those onto the left-hand side of the superior mesenteric artery are not regional for a pancreatic head mass. And any para-aortic artery, para-aortic lymph nodes are distant metastatic lymph nodes. And this is a schematic borrowed from the net. And this 8 and 9, these are the celiac and the common hepatic arteries, and the 14 number 14 station 14 arteries are along the superior mesenteric, and 15 is the middle colic arteries. All the arteries onto the right hand side of the aorta or the celiac and the superior mesenteric artery are regional arteries, and they can come out in bulk. And anything onto the left side of the aorta usually are metastatic lymph nodes. Sorry, I've been telling arteries for lymph nodes. Please pardon me. And the peripancreatic lymph nodes usually communicate with the perigastric, hepatic, and mesenteric lymph nodes, and any involvement of them cause a retrograde lymphatic flow into these territories of the gastric and the mesenteric lymph nodal stations and cause lymphatic dissemination. The common route of involvement of the para-aortic lymph nodes is from the posterior pancreaticoduodenal via the superior mesenteric arterial lymph nodes to the para-aortic lymph nodes. However, occasionally the lymph nodes along the superior mesenteric artery are skipped, and there is direct extension of the posterior pancreaticoduodenal lymph nodes into the para-aortic lymph nodal station. We need to take care of few other adjacent anatomical structures when we are evaluating a preoperative image, and those include the bowel anteriorly, the mesocolon and the root of the small bowel as well, and posteriorly the kidneys and the adrenal glands. If there is contiguous extension into the retroperitoneal compartment, whether or not the adrenal gland is involved, that the adrenal gland may be spared or included in the resection margin with sparing of the kidneys. And in presence of ascites, we usually consider it as a malignant ascites. If not, there is an underlying chronic liver disease or a mesenteric venous occlusion. However, that needs to be confirmed by cytology. And that will be all. Thank you, sir, for the opportunity. And thank you, everybody, for patient listening.